Okay, great. So I'd like to welcome you all to this penultimate session of the Research Forum. My name's Petra Nachmius, and I lead the Population and Social Statistics section here at ESCAP, and I'm very pleased to be your moderator for this session. The session is titled Improving Mortality Statistics, and I think it provides us a nice segue from the previous session, which looked at how to strengthen the death registration and certification. How do we strengthen the input data? And now we're looking at how can we produce statistics and what methods can be used given the data that we have to best produce mortality statistics. We'll be starting off with a keynote address from Dr. Stefan Eremiga, who is Professor of Social Research and Public Policy at the New York University in Abu Dhabi, and he's been working very closely with us on methods to improve the production of adult mortality statistics. So Stefan, without further ado, I'll hand over to you.
Thank you, Petra, for the opportunity to present in this forum. So let me share my slides. So I'm delighted to be able to speak here about potential strategies to improve mortality statistics, and just a little bit of background on data from civil registration and vital statistics system as really the basis for mortality statistics for various reasons. One, especially, is that CRVS is a continuous, universal and prospective system in its essence, which should give a high level of confidence in the data and estimates it generates, allow to disaggregate these estimates across many dimensions, including for small areas of a country or any other jurisdiction. By comparison to this essence of CRVS systems, other data sources such as surveys, censuses, data from health facilities are either too infrequent, might be affected by recall errors, might be affected by selection bias, and especially in the case of surveys, might be often underpowered. So they document too few events to be able to learn anything about mortality. CRVS, because it is a continuous system, also has the advantage in times of crisis that it might give a more complete picture of the impact of a crisis like the COVID-19 pandemic, for example, on the health of a population. And in doing so, it improves on other data sources, for example, those that rely on testing for a particular pathogen to be able to detect a death attributable to that pathogen. And if the coverage of such testing systems is limited, then we only get a partial view of the impact of a crisis on population health. By contrast, CRVS data provide information on direct effects, on indirect effects of an epidemic, as was the case here, for example, on data pertaining to the Republic of Korea and extracted from the human mortality database for the year of 2022, so during the COVID-19 pandemic. Now, unfortunately, in many countries, CRVS systems remain in transition. They do not always function optimally, because some deaths are either never registered or registered, but only after some delays. And in addition, collating, tallying, and reporting the data generated by CRVS system might take time, and errors might creep in at various stages of the CRVS process. In addition to this, these systems are affected by inequalities, and some of those inequalities have been documented very carefully in the context of birth registration, for example, but there are also strong inequalities in death registration, for example, by gender or cause of death. So on the left of this slide here, I show results from a study I conducted with colleagues at ICDDRB in Bangladesh, where we found in a small area a couple of hours away from the capital cities that only 5% of deaths that had occurred in recent time were registered when the deceased was a woman versus 25% when the deceased was a man. So such inequalities in death registration might be pervasive in CRVS systems. So in this context, how can we go about improving mortality statistics that we might derive from CRVS data? So the key questions here from an analysis standpoint are really how to measure the completeness of death registration accurately, meaning out of the deaths that occur in a population as a whole, how many make their way through the CRVS system and become registered and compiled as vital statistics. And we need to do that, including being able to document short-term variations in the completeness of death registration during crisis, like a COVID-19 pandemic or an epidemic of another kind that might prompt sudden changes in the completeness of death registration, and also measuring completeness in subgroups. So what is the completeness of death registration, maybe in some of the less affluent segment of societies or in some minority populations that may have less access to administrative services. And in doing so, the second key question that we have is really how to improve the completeness and timeliness of death registration in general, so that our mortality statistics that we produce rely less and less on global models that are inferred through a number of hypotheses and projections, for example. So some leads about how we might do so. The first one, obviously, is to invest and continue investing in CRVS systems, and the other sessions of this forum have done a great job in covering those various leads and work that is going on in this area. So here in this short presentation, I'll focus briefly on a couple of other leads that might help strengthen mortality statistics, in particular devising record linkages between CRVS and other data sets on mortality that might be available. And second, another strategy might be to use surveys and censuses strategically to inform what we are hoping to assess about the completeness of death registration and to accelerate progress towards more complete death registration. So in terms of record linkages, what do we mean by this? Well, by this we mean a conceptual model whereby we will try to look at two lists of death that are compiled by different recording systems and try to find whether an event is recorded in both systems or in only one of those two systems. And so we do this through a complex process of matching, but that ultimately allows producing data and classifying records in a table, in a 2x2 table like the one you see on this graph. And so this is particularly interesting because it allows us to characterize which events are missed by one system relative to another, but also it allows us to estimate what proportion of events, of deaths in that case, might be missed by both systems. So that's the number Z here. And in doing so, these methods of record linkages require fewer assumptions about population rates and processes than other methods to estimate the completeness of death registration, like death distribution methods, for example. They also make it possible to look at covariates. What are the characteristics of death that are included in source 1 but not in source 2? And what are the characteristics of death that are included in source 2 but not in source 1? So this is particularly helpful. And such studies have been somewhat rare or uncommon in a way to estimate the completeness of death registration, even though there's been a lot of progress recently in computational power and tools to facilitate record linkages that could make such studies a lot more prevalent. And so what are some of the sources that we could use to evaluate the completeness of death registration through record linkages? Well, for example, they include data that are collected at the health facilities or in other health information systems. They might include data that are collected from burial or cremation sites where deceased are handled and might provide some sort of records that we can use from record linkage. They might also rely on data on deaths that are reported during surveys and censuses that also generate lists of deaths that can be matched with data generated by CRVS systems. And there might be other data sources out there. For example, increasingly, obituaries are put online and are available on an ongoing basis. So these might provide some source of data for record linkage. And so this is something that could potentially be generalized a lot more. And there have been calls to that extent formulated in previous years, but that should be followed a lot more closely. Then the strategic use of surveys and censuses. So there are often concerns that the data generated by periodic surveys and censuses might act as a substitute for CRVS data. So if we have data from a DHS or from a census, the need to invest in CRVS data might be perceived wrongly as not as pressing. So I suggest that this is a wrong view of surveys and censuses, but rather that there are complementarities between surveys and censuses that should and CRVS that should be exploited much more systematically, but those require innovations in surveys and census methods. And so those innovations are to actually ask questions about death registrations in surveys and censuses, to attempt to measure mortality in subgroups in surveys and censuses, and to increase the periodicity of data collection of survey data through various methods. And I'm going to briefly show how that would work. So asking about death registration might be particularly helpful. And if you think as a comparison to birth registration, this is something we already do widely in the context of birth registration. So on the left, I show you the adoption of questions on birth registration in demographic and health surveys since 1985. So early on, very few surveys asked such questions. But since the 2000s, these questions have really become a staple in DHS questionnaires. The same cannot be said about death registration, with notable exceptions, like the National Family Health Survey in India that systematically asks such questions. And not including questions about death registration in surveys is a missed opportunity, because these questions would allow detailed assessments of, on one hand, the completeness of death registration, but especially of inequalities in death registration along many dimensions that pertain to households or the deceased. They would also allow further inquiries about hurdles that households might face regarding the registration of deaths. For example, if we ask households why a particular death might not have been registered, and here you have results from a study of this kind conducted in Guinea-Bissau in West Africa, and comparing reasons for not registering births and deaths in that particular setting. Similarly, measuring mortality in subgroups in survey would also be important, because at the moment, the benchmarks we use to evaluate the completeness of death registration rarely exist for population subgroups. And that's largely due to limitation of survey and census data, particularly at adult ages, because those data sources only ask questions about generally the age and the sex of the deceased, no other data on characteristics of the deceased, like, for example, their educational status or their marital status, and so on and so forth. And in various studies recently, together again with colleagues at ASHIDI-DRB, we have tried to see if it was in fact possible to ask about more characteristics of the disease. Then in the case of education, for example, we find high level of agreement between reports that we might get during a retrospective survey and gold standard like self-reported data on education among the deceased prior to their death. And so this might help track inequalities in death registration more closely within certain groups than we're able to do at the moment. And finally, as pertains to the periodicity of data collection, surveys, if we are able to conduct them more frequently, might help us assess completeness of death registration, for example, during crises like the COVID-19 pandemic, and they might help us identify what factors contribute to the resilience of death registration systems during crisis. So here, there's a very promising avenue of research that pertains to mobile phone surveys, because such surveys can be conducted remotely, frequently, at limited costs, and in times when, for example, household visit might not be possible due to conflict or public health restrictions. And those surveys might include mortality-related questions, including questions about death registration, that might help us to detect whether the coverage of death registration is declining during a crisis or might be increasing because at all of a sudden people are more aware of the need to register deaths. So all of these are potential leads to further strengthen the use of CRVS data and improve the completeness of CRVS data. And in doing so, I try to emphasize additional, less commonly used strategies to achieve those goals, in particular as they pertain to record linkages and innovation and survey and census method that might further strengthen CRVS data and its expansion. Thank you very much.
Thank you, Stefan, for sharing such an interesting and in some places very innovative work. Our next speaker is Dr. Maria Midia Cabamalan, who is from the Population Institute at the University of the Philippines. And she will be presenting to us her research on male-female disparities in potential years of life lost due to premature mortality in the Philippines. So here we're going to see very much the use of mortality statistics.
That's correct. Thank you, Petra. So on behalf of my co-authors, I'm presenting the preliminary results of our study on male-female disparities in potential years of life lost due to premature mortality in the Philippines. May I have the first slide, please? My name is Maria Medea Cabamalan, professor at the University of the Philippines Population Institute. Next slide. Premature mortality or deaths occurring at any age lower than the life expectancy adversely impacts the social and economic performance of a country. In the Philippines and for the population less than 70 years old, non-communicable diseases such as cardiovascular disease, malignant neoplasm or cancer, diabetes, and chronic respiratory diseases have been the leading causes of death in the last decade. In recent years, external causes like land transport accident moved up the ranks, and in 2020, suspected or probable COVID-19 was the number 4 cause of death. There are some differences in ranking by sex. While cardiovascular diseases and cancer are the top 2 leading causes of death for both the male and female populations, there are a few notable differences by sex, which I will skip for now in the interest of time. Next slide, please. Life expectancy data generally indicate that men have shorter lives than women, but only a few studies have been made on the differences of mortality between males and females in the Philippines, and cause-specific mortality studies are scant. A potential indicator to use in studying male-female disparities in premature mortality is by the use of potential years of life lost, which we will call PYLL in this presentation. The PYLL refers to the number of years that a person would have lived had they reached a specified age, or in other words, a measure of the years of life not lived due to premature mortality. This measure provides insights on what causes of death can be prevented in order to maximize a person's or a population's contribution to society. Next slide, please. This study thus aims to produce estimates on sex-specific potential years of life lost, or PYLL, due to premature deaths from NCDs, external causes such as land transport accidents and intentional self-harm, COVID-19, and other leading causes of death. We estimated and compared the PYLL due to each of the said causes by sex at the national level for the period 2010 to 2020 and by region for year 2020. For the data and methods in the next slide, we use data on deaths from the Vital Statistics Division of the Civil Registration Service of the Philippine Statistics Authority. We also used census counts and official population projections in estimating the PYLLs. In the next slide, we show the formula we adopted from the OECD. We used the cutoff age of 70, which best reflects the life expectancy at birth in the Philippines. For the period 2010 to 2015, life expectancy at birth is estimated to be 68 for males and 74 for females. For the period 2015 to 2020, these are expected to be 70 and 76 respectively. The estimates by region were standardized for each sex using the Philippines age structure to eliminate the effect of the differences in the age-sex structure of the regional population. In the next slide, we show the causes of death that we included in the study, particularly non-communicable diseases, external causes, communicable or infectious diseases, and diseases of the liver. Causes of death not listed here are categorized as other causes. The classification used the ICD-10 codes, version 2016, as applied to the Philippine Civil Registration and Vital Statistics System. However, codes in relation to COVID-19 were based on the 2019 version. In the next slide, I show you some limitations and delimitations of the study. We did not adjust the numbers for under registration, although using the empirical completeness model, our estimate of under registration is at 88% in 2019 and slightly lower at 87% in 2020, probably due to the COVID-19 lockdowns. The estimate for 2021 is 95%, although we do not have the data for the 2021 yet, and this data is not included in this presentation. While the Philippines has 17 regions and completeness of death registration range from 12% in the Bangsamoro Autonomous Region of Muslim Mindanao, or BARM, to 95% in the National Capital Region, or what we call NCR, in 2010. And this improved to 15% and 97% respectively in 2020. The improving but still low death registration in BARM, which was estimated to be 20% in 2021, may be affected by the cultural practice of Muslims wherein burial must take place as soon as possible after death, which is within 24 hours. Thus, the death may or may not be reported to the local health officer within 48 hours, nor registered at the local civil registry offices after burial. Such low registration of deaths in BARM results in unusually low PYLLs and thus lie as outliers. For this reason, while we have estimates for BARM, we did not include their data in the analysis by region. Also excluded in the analysis are foreign nationals who died in the Philippines and Filipinos who died outside the country. Those with no information on age or sex were likewise excluded in the analysis. Now, for the results in the next slides, we show in this slide the percentage distribution of deaths by cause for both the number of deaths and the estimated PYLLs. Overall, there are 372,000 deaths among population under age 70 in 2020, and this translated to a potential 7,600 years of life lost per 100,000 population on average. Here we note that while more than half of the deaths are due to NCDs, their estimated PYLLs result to only 38% of the total. In contrast, while deaths due to external causes accounted for a total of 8% of the total deaths, their corresponding PYLL represents 13%. These patterns indicate the importance of using PYLL as an alternative indicator in studying mortality, particularly as it emphasizes the impacts of deaths in the younger age groups. Now, focusing on the male-female differences in the next slide, we show that except for cancer, PYLLs due to most causes of death are greater for the male than for the female population. For example, cardiovascular diseases are twice higher for males than females. For intentional self-harm, it's 4 times. For land transport accidents, 7 times. And for assault, 9 times higher for males than females. Additionally, for HIV, the estimated PYLL is 13 times higher for the males than the female population. Now, in the next few slides, I will show some trend estimates on PYLL for specific causes of death. But here we start with the trend for all causes by male-female. At the national level, for all causes of death, we see a drop in PYLLs from 2010 to 2020. The estimate dropped from 11,000 to 9,500 per 100,000 male population. And for females, the estimate dropped from 6,500 to 5,700 per 100,000 female population. In the next slide, we show some causes of death, but the PYLL, however, did not improve for some causes of death. For example, the PYLL for cardiovascular diseases for both males and females hardly declined over the last decade. In the next slide, we show intentional self-harm and HIV. PYLL remarkably increased for males for both these causes of death. For diabetes, which is not part of the slide, the PYLL increased for both the male and the female populations. In contrast, in the next slide, in contrast to almost all causes of death, we found higher losses of potential years of life among the females than males when it comes to malignant neoplasm or cancer. And in the next slide, we see that for cancer, the gap in PYLL is generally widening over time. It's the graph on the left, with the male estimates declining and the female PYLL in the upward trend. For diabetes, the gap between male and female PYLL seems to be narrowing over time, except for the last year, which seemed to have widened a little bit. Now, in the next slide, for other causes, we do not see clear patterns like for mental and behavioral disorders. For land transport accidents, we see an increasing trend for the male population until 2019 and a substantial drop in 2020. Presumably due to the lockdowns imposed in relation to COVID-19. In the next slide, we also note the substantial drop in PYLL among the male population from 2010 to 2020 in terms of assault as a cause of death, which led to a narrower gap between the males and females. We would just like to point out that the data on HIV, assault, and intentional self-harm may be affected by reporting bias, as there is stigma when these are reported as the underlying cause of death. Patient confidentiality, loss of benefits or insurance, cultural beliefs, and legal implications are also some of the other reasons for not correctly reporting these causes of death. Next slide, please. By region, for 2020, here we show the map of the Philippines by region, with the darker shades indicating higher number of deaths. We see that regardless of cause and of sex, deaths are highest in Calabarzon, the region located just south of the National Capital Region. This is followed by the NCR and Central Luzon. Except for BARM, the Cordillera Administrative Region registered the lowest number of deaths in 2020. The next slide shows a graph with the standardized PYLLs for all causes for each of the 17 regions by sex for 2020. The blue dots represent the male PYLL, while the orange dots represent the female PYLLs. The purple triangle represents the PYLL for both sexes. The lines between the two dots indicate the gap in PYLL by sex. Our estimates of the PYLL indicate that for all causes of death and among males, the highest number of years of potential life loss are found in the National Capital Region, in Calabarzon, in Davao Region, and in Western Visayas. In contrast, the lowest estimates are found in Cordillera Administrative Region and Eastern Visayas. Among females, the PYLL estimates are likewise found in NCR, Calabarzon, and Davao, and in Central Visayas, while the lowest PYLL estimates are also found in CAR and in Soxargen. I think it's quite noticeable that the dots for BARM are very low and lie as outliers, and that's the one that you see at the bottom. In the next slide, we just like to highlight a few specific causes of death. For cardiovascular diseases, we see that the disparity between males and females is highest among those from the National Capital Region, with the male PYLLs 2.4 times higher than the estimate for the females. For diabetes, the widest male-female gap is found in Calabarzon, even as we see that the highest PYLL is found in Caraga. For chronic respiratory disease as a cause of death, the Bicol region has the highest PYLL, but the male-female gap is widest in Western Visayas. Next slide, please. What the team noticed is that the high PYLLs are found in regions with metropolitan cities like NCR, Davao, Calabarzon, and Central Visayas, which may point to lifestyle-related causes of death. A study by Yusuf et al. In 2001 showed that in developing countries, the high burdens of cardiovascular diseases may be due to urbanization and comorbidities such as diabetes and hypertension, as well as due to relatively young population structures. Similarly, another study noted that the large increases in type 2 diabetes in Southeast Asia is associated with lifestyle changes related to urbanization and industrialization. To conclude, we found that PYLL is higher for male than female populations for all causes of death except for cancer. Premature deaths cause an average of 9.5 thousand years lost to men compared to 5.7 thousand years lost to women. Cardiovascular diseases and diabetes remain as the top cause of death in the country. Next slide, please. Which tends to be lower for the females than for males, but higher for females than males for cancer. The male-female gap in PYLL due to intentional self-harm is wide, with more years lost to males than females. In the next slide, we reiterate that PYLL estimates show higher losses of potential years of life lost for the male than the female population. And while there is a general decline in PYLL for all causes, the PYLL for some causes of death did not necessarily improve over the years for both the males and females. And the male-female disparities are largely attributed to lifestyle choices and behavioral patterns related to gender norms. Next slide, please. As we continue to process the results of this study, we hope to explore further some types of causes of death, for example, in cancer, where there might be higher PYLLs due to specific types of cancer for one sex over another. We also hope to include the 2021 data in our analysis and examine how much COVID-19 affected the PYLL estimates. Finally, as earlier suggested, we will try to examine deaths that occurred in the communities versus in the facilities. And perhaps use the methodology that Dr. Adair just described in the earlier session to adjust the cause-specific deaths in the Philippines, although we still need to study this methodology in particular. Thank you, and thank you also to CDC Foundation for supporting this study.
Thank you very much for that presentation. I don't see yet any questions or comments in the chat box, but participants are welcome to put any thoughts in the chat box. So while people are thinking of some questions, I think we can go now to our next presentation. And this is by Dr. Saman Gamage, who is a Senior Technical Advisor at the CDC Foundation in Sri Lanka. And he's going to be speaking about the evaluation of the implementation of iris automatic coding system in the Philippines. Thank you.
Thank you very much. Good afternoon, good morning, good evening, everyone. My name is Saman Gamage. I'm a medical doctor and a public health expert working as a senior technical advisor to the Bloomberg Philanthropies Data for Health initiative of the CDC Foundation. I play another role as a public health specialist and the head of the Department of Research and Evaluation at the National Institute of Health Sciences, Sri Lanka. My topic today is evaluation of the implementation of IRIS automated coding system in the Philippines. Before starting, I would like to acknowledge the support given by the Bloomberg Philanthropies Data for Health initiative to implement this project in the Philippines, not forgetting all the staff of Philippine Statistics Authority, commonly known as ESCA, including mortality coders. I would also like to acknowledge the technical support of the Australian Bureau of Statistics in implementing IRIS automated coding system in the Philippines. Imagine a world where medical coding is no longer a tedious and time-consuming task, but a streamlined process that saves lives. Today, I'm thrilled to share the exciting results of our intervention to introduce IRIS automated coding in the Philippines and its potential for revolutionizing healthcare in the region. As you know, reliable mortality statistics are crucial for public health, medical research, evaluating interventions, and setting health priorities. The underlying cause of death, which is the disease or injury that initiated the train of morbid events leading to death, is the most important aspect of the death certificate. In the Philippines, like in most countries, the source of cause of death data is the medical death certificate. In the Philippines, the population is around 103 million. Nearly 500,000 deaths occur annually, and about 90% of them are registered. Mortality coders at the Philippine Statistics Authority code the death certificates completed by the physicians. However, before 2016, when mortality coding was manual, the coding of around 580,000 death certificates took 2 to 3 years to complete. Next slide, please. Why do we automate mortality coding? So countries like Philippines with higher number of deaths, mortality coders code large numbers of death certificates. When it is done manual, coding increases working workload for coders, and due to manual coding, its non-uniform coding can lead to errors. So when automated coding increases timeliness, accuracy, and consistency of coding. Next slide, please. Talking about IRIS, IRIS is an interactive coding software developed for coding causes of death and selecting the underlying cause of death. This is created by a group of experts, and all decisions implemented in the software are a result of discussions at the mortality reference group of the World Health Organization. Therefore, we can be sure about the outputs from the IRIS software. Next slide, please. IRIS is based on the International Medical Certificate of Cause of Death recommended by the World Health Organization, and causes of death are coded according to the ICD-10 and mortality classification rules. The coding of causes of death and the selection of underlying cause of death in IRIS is entirely automated, and IRIS uses a tool known as mortality decision tables for the underlying cause of death code selection. Mortality decision tables were initially developed by NCHS, National Center for Health Statistics in CDC Atlanta, and subsequently the maintenance and development of decision tables were taken over by the IRIS Institute. Now what we are seeing on the screen is the loading screen of IRIS automated software. IRIS uses the rainbow as its symbol, and this photo was taken in Stockholm from a hotel window in the evening. Next slide, please. There are some prerequisites for IRIS implementation. So whenever a country is required to implement IRIS automated coding, so we have to check whether the country has fulfilled these requisites. The first one is country uses the WHO recommended format of the medical certificate of cause of death. Philippines still do not use exact version of the 2016 WHO medical certificate of cause of death. However, Philippines uses a death certificate with two parts, part 1 and part 2, and then time interval column. Even though there are only 3 lines in part 1, it is still compatible with the WHO format. And all coders should be trained in manual mortality coding. This means even though we automate mortality coding, automated software will not replace the manual coders. And if a country wants to use the text entry version of IRIS, which is the most useful version of IRIS, a local language dictionary is available. That is another requirement. However, in the Philippines, medical documentation is done in English. Therefore, there was no need to translate the dictionary into local language, and we could easily adapt an available English dictionary and customize it to Philippines. Another requirement is the IT support. Local IT support is mandatory for the implementation and maintenance of IRIS software. Can you go to the next slide? In 2016, Bloomberg Philanthropies Data for Health initiative assisted in implementing IRIS automated coding system in the Philippine Statistics Authority. The main problem we had was to link existing Philippines decentralized vital statistics system to the IRIS software. Therefore, the IT department of the PSA had to develop a computer utility program, commonly known as interface program in the Philippines, to link district decentralized vital statistics system to IRIS. So interface program is able to import death certificates from DVSS to IRIS. After processing, it is also able to export processed data back into DVSS. Next slide, please. So in 2017 February, we trained all the coders of Philippine Statistics Authority in manual mortality coding using mortality decision tables. So this is one of the pre-requirement to implement IRIS automated coding. So that was done in February 2017. Next slide, please. Yeah, then after the development of the interface program, the computer utility program to connect DVSS to IRIS, we pre-tested this program in April 2017, and we processed more than 40,000 death certificates using the interface program. And we found that the utility program is working fine. Next slide, please. Then the IRIS training took place in July 2017. This was a 5-day training which provided all the coders hands-on experience in using IRIS automated coding software. And there was also a training on using the computer program, interface program. Next slide, please. The objective of our study was to ensure that there are no significant inconsistencies in the data and to ensure that the IRIS coded mortality data are of sufficient quality to be released and disseminated in a timely manner. In a nutshell, we wanted to ensure that mortality data for the Philippines are standardized. Next slide, please. Death certificates data from 2017 to 2019 were analyzed and evaluated for apparent errors and inconsistencies. And cause of death trends were examined for plausibility. And then we calculated cause-specific mortality distributions for each of the 3 years and compared for consistency. And annual numeric and percentage changes were calculated and compared for all age and sex groups. And then we also analyzed the typology, reasons, and proportions of IRIS rejects. In other words, just because we implemented the automated coding system, IRIS automated coding is not able to code all the death certificates automatically because there can be some number of rejects. So we wanted to study the reasons and proportions of iris rejects during this evaluation. Next slide, please. And we did 3 consecutive evaluations in 2017, 2018, and 2019. And talking about the results, we calculated deaths for 20 leading causes from 2017 to 2019. And figure 2 explains the 5 leading causes of death from 2017 to 2019 period. And there are no major inconsistencies, and population growth is reflected in the growing number of deaths each year, which amounted to 2% between 2017 to 2018 and 5% between 2018 to 2019. Next slide, please. So this is the figure I was talking about, figure 2. And then figure 3, we calculated cause-specific mortality fractions for 20 leading causes of death. And figure 3 shows the cause-specific mortality fractions for the 5 leading causes of death. The cause-specific mortality fractions for 20 leading causes of death showed a reassuring stability. Next slide, please. Now, as I told you before, IRIS is not able to code all death certificates automatically. Some records may be rejected due to several reasons. For example, some records can be rejected for code reasons. This means IRIS cannot assign an ICD code for the specific diagnostic expression by the doctor, because doctors are known to write diagnosis with different expressions. So this is usually the commonest type of rejection. Other rejects may be due to some interval reasons, that means time interval reasons, or maybe IRIS doctor is not being able to understand some causal relationships, or IRIS decision tables may express these some ambiguous or maybe relationships. And sometimes if the death is due to an external cause, main injury code may be required. So these are some of the reasons for rejections. So in the beginning, the proportion of rejects was as high as 60%, but IRIS rejects, mainly code rejects, were reduced later due to the updates to the dictionary and standardization tables. So what we did was we updated the dictionary to include common diagnostic expressions of Filipino doctors and updated the standardization tables to read common expressions using filter in and filter out functions. For example, diabetes mellitus may be expressed in different ways by doctors. However, the standardization tables makes IRIS software to read any other expressions as the given type of diabetes mellitus. And also, there was great improvement in timeliness, because previously it took about 2 to 3 years to release data, but that was improved to 1 year. And also, the quality and consistency of coding was greatly improved. When the coding was done manual, there were differences between coders. However, due to the use of same software by all the coders in the Philippine Statistics Authority, the consistency and the quality was greatly enhanced. Next slide, please. The extensive use of mortality data for public health programs and research purposes has led to need to improve the accuracy of cause of death statistics from time to time. The quality of mortality data primarily depend on the quality of cause of death certification and coding. Using IRIS by the Philippine Statistics Authority helped them strengthen the centralized coding practice. Because IRIS is used centrally by the Philippine Statistics Authority, the training, including updates, dictionary, and standardization table maintenance, is made very easy. Compared to manual coding, automated coding also increased the consistency of coded data by the coders. The use of IRIS also enhanced the comparability of cause of death data by using software which is widely used internationally, because IRIS software is being used in many countries in Europe. So the same software is being used in Philippines. And to our knowledge, Philippines is the first Asian country to use IRIS automated coding system. Next slide, please. So we were able to conclude that Philippine mortality collection system functions well, and the Vital Statistics Division at the Philippine Statistics Authority is fully able to run IRIS and code the rejects manually. The data compiled in the standard annual tables are of sufficient quality to be released, to be used for policy. Next slide, please. So based on our conclusions, we were able to recommend IRIS software be used as a key tool for the cause of death coding. And now the cause of death coding in PSA is fully automated, and 100% of the records are coded using IRIS automated coding software. And for consistency of process, it is recommended that in future, perinatal deaths are also coded using IRIS. Another recommendation was to upgrade IRIS to the latest available version 5.8.1. So by the time I present this paper in this forum, we have already done the training in early last month, to train all the coders in IRIS version 5.8.1. Next slide, please. So our next steps will be, we have heard now Philippines Department of Health is looking forward to implement ICD-11 in future. So the next step for PSA would be the implementation of IRIS version 6 for ICD-11. We know IRIS version 6 is still under development, so they have the opportunity to choose whatever the tool automated option available for ICD-11 in future, to continue automated coding practice even with ICD-11. Thank you very much.
Thank you. It's great to see this focus on cause of death reporting, which we know is very challenging, and also this close collaboration between the Department of Health and PSA. So I still don't see any comments or questions in the chat box. So I think we can move then to our final presentation. This one is quite close to my heart because I had the privilege of being able to work with Professor Moultrie on this research. Our presenter is Professor Tom Moultrie, who is a Professor of Demography and the Director of the Centre for Actuarial Research at the University of Cape Town in South Africa. So Tom, over to you.
Thank you very much, Petra. And as you've just mentioned, this is work which I've done in conjunction with ESCAP to try and form a more complete picture of what is happening at a regional level with death registration in the ESCAP region. Next slide, please. I'd like to just briefly acknowledge my contributing co-authors to this work, Elise Boiteau Monteville, Petra Nachmias, and Tanya Segerson, who all contributed meaningfully to this work, as well as the staff, both at the UN Population Division and the ESCAP Statistics Division, who gave inputs and advice. And obviously, you'll see this from the data which we produce and we present today, all the countries that have contributed data to the study. Next slide, please. But it's now common, we've seen it in so many presentations over the last 2 days, that the registration of death matters. The timely, accurate, complete death registration registration of deaths is foundational to the planning and implementation of national health policies. We've seen in the last 3 years how essential that accurate, timely, and complete death registration is to managing pandemic responses and developing national responses to pandemics. And obviously, it's also a crucial component of legal identity. Next slide, please. In the last decade, concerted efforts have been made in the ESCAP region, the so-called Asia-Pacific CRVS decade, which ran from 2015 and will finish at the end of next year, to expand the coverage and completeness of national CRVS data. But one of the things which became clear around about the midpoint of that CRVS decade was that the completeness of death registration in many countries remained and remains uncertain. And so what we set out to do here is to provide a set of regional as well as cross-national estimates of completeness of death registration in the ESCAP region. Next slide. Our focus here is on the civil registration of deaths reported by countries. There are other sources of data. Professor Helleringer mentioned some at the start of in his keynote address of the session. And there are other sources of data as well. For example, health facility data, that is data obtained from hospital death records. And those might offer an alternative way of approaching the problem of how to estimate completeness of death registration. But doing so would likely introduce unpredictable error in the cross-national comparisons because of different types of health facility data collection systems, either nationally or regionally. So in 2019, before the COVID pandemic, a questionnaire was sent to countries in the region as part of a monitoring exercise, and that was really meant to be at the midpoint of the CRVS decade. Of the 58 countries in the region, 45 of those 58 countries responded to the questionnaire, and 40 of the 58 countries were able to provide data on the death registration from their CRVS systems. Next slide. Where we didn't have data, we supplemented these from other sources, including that from the UN Statistical Division Demographic Yearbook. You can see on this slide that the vast majority of the data which we used in this analysis either came from regular publications from the National Statistical Offices, that's the top line, or from the ESCAP baseline and midterm questionnaires, that's the bottom line, which was the data which was sought as part of that mid-CRVS decade evaluation and monitoring. The next slide, please. In total, we had data available for 2018 from 43 countries. If you look at the column for 2018 here, we see that there are 48 countries with data for 2018. 43 of those countries provided actual data for the year 2018. 4 countries were only able to provide data for pre-2016, 2 for 2016, and 4 for 2017. The 5 countries which were not able to provide us data, and we see those in the final column of this table, are the China, the DPRK, Turkmenistan, Indonesia, and the Solomon Islands. And we set out to try and estimate the completeness in those 5 countries for 2018, which would bring the total number of countries for 2018 from 43 up to the 48 shown in that table. However, next slide. The problem comes that if one's trying to produce regional estimates of completeness of death registration or unregistered deaths, 2 of the countries who were not able to provide us with data are 2 of the biggest countries in the region by population, China and Indonesia, which therefore contribute most to the numbers of deaths in the region. And this was a particular problem which we had to try and resolve. Next slide, please. So in order to estimate completeness of death registration at a national level first, and then ultimately aggregated to a regional level, requires a counterfactual of the estimated number of quote-unquote true deaths, which are estimated to have occurred in a country's population. For this, we made use of the UN Population Division's World Population Prospects, the most recent version, that's from 2022, which provided estimates of national deaths for the corresponding year reported by the countries. And I record again that most countries were able to provide data for 2018. Where the estimates of completeness exceeded 100%, in other words, countries were reporting more deaths than were predicted or projected by the UN World Population Prospects, we capped those at 100%. The reasons underpinning this, the underreporting or that completeness in excess of 100% could be that late registrations might have been included in reported deaths from a country. The UNWPP may have underestimated mortality in some situations, and particularly in small island states, random fluctuations in the data might have led to completeness exceeding 100%. So in the case of 3 of the 5 countries with no data, that is the DPRK, Solomon Islands, and Turkmenistan, the approach we adopted was similar to that which had been set out by UNICEF for estimating completeness of birth registration. And what they did here is that they said, let's, in the absence of any other data, let's apply the average completeness for other countries in that subregion to those countries where we have no data. In the case of these 3 countries, each of the 3 countries represents a very small proportion of deaths in their respective subregion. And so the impact of error is likely immaterial at either a regional or a sub-regional level. Next slide, please. However, in the case of China and Indonesia, we needed to adopt a somewhat different approach because of the materiality of these estimates from these countries on regional levels of completeness estimation. A literature search reveals an estimate of completeness of 74.2%, and that was in about 2016, based on the China cause of death reporting system. And that was work by Zheng, Adair, and Wang, published a couple of years ago. We considered these data and other sources which we lay our hands on, and we came to the conclusion that there was a moderate degree of uncertainty about what the level of completeness of registration in China was. And ultimately, we set out to assume, or we assumed, that the completeness of death registration in China was uniformly distributed between 65 and 80% in 2018, which would give a mean of about 72.5%. We used a uniform distribution as there's no strong prior about the likely shape of the underlying distribution. And that mean figure for China of 72.5% would place it somewhere between Bhutan at the low end at 65% and Macau at the upper end. And at the mean it's comparable to India or Tajikistan. In the case of Indonesia, however, even less data were available, and what data we were able to access was indicated widely discrepant estimates and a strong indication that completeness in the country did not comport with the sub-regional average for the sub-region of the ESCAP region in which Indonesia is located. And so here we had to assume a high degree of uncertainty as to what the completeness of death registration in Indonesia was, with a uniform distribution of somewhere between 40 and 65%, with a mean of 52.5%. At the lower bound, this would place Indonesia's completeness somewhere close to the Lao People's Democratic Republic, at the upper bound, somewhere close to Bhutan, and at the mean comparable to Nepal. Next slide. So for the 5 countries without data, we assumed that for the following levels of completeness. For the DPRK, which is in the East and Northeast Asia subregion, we assumed completeness of 99.3%, which is very high, but also given the nature and characteristics of the DPRK, that is perhaps not unreasonable. In the Solomon Islands, which are in the Pacific subregion, we ended up assuming completeness of 74%, and for Turkmenistan in North and Central Asia, completeness of 96.2%. And as I've just described, for the People's Republic of China and Indonesia, we assumed a mean values of 72.5 and 52.5%, with a distribution surrounding those estimates. Next slide, please. So if we look at the estimates of completeness of death registration in the ESCAP region in 2018, and I must just quickly record that the asterisk there is because some countries, as was shown on an earlier slide, were not able to produce estimates for 2018. And so effectively what we have assumed is that where countries were not able to provide data for 2018, that there had been no change in their completeness of death registration from whenever they were able to report the data up until 2018, which if anything is a likely conservative assumption. And what we can see in these data is a large number of countries in the region with completeness in excess of 90%. Some of them are very small countries, American Samoa and French Polynesia, Guam, for example. And at the other extreme, Timor-Leste, Bangladesh, Vanuatu, Afghanistan, and Papua New Guinea, which doesn't even represent itself on that figure. Rather lower levels of completeness. Next slide. If we allow for that uncertainty in the completeness of death registration in both Indonesia and China, this figure shows what we think the underlying distribution is, or what the range of estimates of completeness of death registration in the entire ESCAP region is likely to have been in 2018. And we can see that we're 95% confident that the regional completeness of death registration lies somewhere between 71.8 and 76.8%, based on those underlying distributions assumed for China and in Indonesia. Next slide, please. In total, in 2018, the UNWPP estimated that there are roughly 32.1 million deaths in the ESCAP region, of which nearly 24 million had been registered, leaving about 8.25 million unregistered deaths in the region in 2018. Of those 8.25 million unregistered deaths, the vast majority, 7.2 million or 87% of those were to be found or were estimated to have occurred in China, India, Indonesia, Pakistan, and Bangladesh, which is not really surprising given the relative weight of those 5 countries in the overall contribution to the population of the region. But what we can see here is that there is generally high levels of completeness across the region, with North and Central Asia indicating about 97% completeness, whereas the other 3 other regions showed completeness between 71 and 77%, and South and Southwest Asia, which is amongst the region with the most deaths according to the UNWPP, had completeness of around about 2/3 in 2018. Next slide, please. What we have seen through this evaluation of the CRVS data in the countries is a clear indication of improvement in completeness of death registration in many countries in the region. But the fact that there are still 8 million or 8.25 million unregistered deaths has adverse consequences. It has adverse consequences for individuals and their families, especially the most vulnerable and marginalized, who, as has been mentioned by other presenters, are more likely to have their deaths left unregistered. It also has adverse consequences, as I've noted, for pandemic responses and preparedness, and to be able to plan and prepare for future pandemics. And we need to know whose deaths are not registered. In this exercise, we were not able to delve into the number of unregistered deaths by age or by sex, and clearly that is a matter for further attention. Next slide, please. So, while completeness is improving, we also need to be able to assess the quality of the data being collected and being reported by age, by sex, by region. In other words, to do those inequality assessments, which are one of the benchmark indicators of the overall quality of CRVS data. And to do this, we're going to need more targeted inequality assessments. We're going to need to more carefully analyze the data of the currency of the registration of deaths to establish what proportion of deaths being reported in every year in every country are late registrations versus those which are being reported within the national statutory limits set by each country. And we need to have countries commit to record deaths and to report their deaths by the date of death and not the date of registration. Next slide, please. The report on which this presentation is based is available. It's shown here. The URL is shown here. The slides will be made available after the workshop is over, and so you can click through and find that link. We would appreciate any further feedback on that report. And I'd like to thank you all for your attention. Thank you very much.
Yeah, thank you, Tom. And just to highlight as well, what we were delighted about as a part of this research was really for the very first time we could come up with a regional estimate of the number of unregistered deaths. And until this point, it was an unknown. So at this point in the other sessions, we've been moving to meet the authors' rooms. However, we've been finding that we get a lot of attrition and they become quite small. And actually this session is quite a bit smaller in terms of participation than the other sessions. So what we suggest is that we remain in plenary. And since we're a smaller group, we hope that people will have a chance to ask questions. And also this allows, I think the authors can also learn from the questions since the papers are quite relevant to one another. If anyone wants to contribute, to ask a question or make a comment, please do raise your hand or write a comment in the chat box. I would perhaps ask, since I know that the room hosts already have a couple of questions to kick things off, maybe just to get the ball rolling, I can call on Nicola, if you have a question that you would like to, or a comment to pose to the author.
Yeah, absolutely. So my question will be for Saman. Hopefully you're still hanging out with us in the, oh yes, there you are. So I was interested if you could explain a little bit more for the participants around kind of the process involved in creating this local language dictionary for IRIS, a little bit about kind of how it's done and who you need to get involved and timelines to get that up and running is one of the important prerequisites. Thank you.
Thanks, Nicola, for your question. Actually, if any country is planning to use a local language dictionary, now in the IRIS user reference manual, there are instructions for the development of the dictionary. So IRIS, at the time of installation, it comes with a dictionary, but it has a limited number of entries. So what we did for Philippines was we received the dictionary from ONS, UK Dictionary, and then we customized ONS dictionary to Philippines. What we did was PSA had some dialogue with the Department of Health and discussion about the common diagnosis used in the Philippines. And then those diagnoses were included in the dictionary. And then there were some common diagnostic expressions. For example, in the Philippines, a common diagnostic expression is community-acquired pneumonia high risk. The high risk, the suffix is not a medical term, but it is used in the Philippines. So we had to use the standardization tables to IRIS to read community-acquired pneumonia high risk as community-acquired pneumonia. So what we did was we used the filter in, filter out function in the standardization tables for IRIS to be able to read these diagnoses. And other than that, there were quite a number of other common diagnoses and that we had to include in the dictionary. However, for a non-English speaking country, then maybe the dictionaries are also available in French, German, and other languages, Spanish and other languages. Then they will have to copy the entire dictionary and then create a new dictionary with new disease entries and the compatible ICD codes. So it will be a big process. Anyway, to make the dictionary manageable, so dictionary, it can have large number of entries, but we use standardization function to minimize the size of the dictionary. For example, type 2 diabetes mellitus. So maybe written by doctors in different ways, type 2 DM, T2 DM. So we don't have to enter all these entries into the dictionary. We use standardization function for iris to read all these expressions as type 2 diabetes mellitus. Thank you.
Okay. I don't see any hands or any comments, so maybe I'll turn to Alexis if you have any questions for Tom.
Yes, thanks, Petra. I do have a question for Tom. First of all, thank you so much for the presentation. I thought it was very insightful, and I was quite impressed by the methodology used and your ability to overcome the challenges related to data gaps. So I'm usually very curious about the methodology that is used in studies, and I was wondering, in your opinion, what could be improved in terms of the data collection and analysis if we were to conduct a similar study in the future, and also take into consideration the potential impact of COVID? Because I'm assuming that a study like this is very much dependent on the accuracy of the data that is being reported by the countries. So I was wondering if there are any lessons that you learned through the process that could be used in future studies like this. Thank you.
Wow, thanks, Alexis. Those are heavyweight questions, and I thank you. On the first point, kind of on the methodology, what we were largely able to do was to use countries' reported data, and the only problem really lay with the 5 countries who did not participate in the process, and we were trying to establish an overall regional benchmark. It's obviously less than ideal. To have particularly 2 of the most populous countries in the region not providing data which could be directly used, and so the first thing is that is not so much a data problem as a political issue about how best to get buy-in at a regional and at a global level for how to sort out these data and to make these data available. That said, kind of one is obviously also a little bit uncomfortable with the even adopting the kind of UNICEF type approach. I think that in the cases here with the DPRK, Turkmenistan, and the Solomon Islands, I think that methodology was probably reasonably sound, and certainly the results do not look out of keeping with what we might have expected given those 3 countries. So I think all told, we are reasonably comfortable that for the first time ever, we were able to come up with a reasonable estimate of the completeness of death registration at a sub-regional and at a regional level in the ESCAP region. But you've pointed to many other aspects as well. Firstly, these data from 2018. So in some ways, we are driving a car looking in a rearview mirror. On the upside, it was 2018, which was before the COVID epidemic and before it hit. And we know that not only did deaths increase, but often countries, civil registration, vital systems, the NSOs, all of them struggled to record and capture deaths during that period. We also have a problem with the counterfactual as to what would have been the number of deaths in 2020 or 2021 as a result of COVID. Because while the UN World Population Prospects does try and make some allowance for COVID mortality, those estimates themselves are drawn from a much bigger project undertaken by the WHO in the last 2 years to try and estimate excess deaths. And while again that methodology of the WHO task team is interesting and fairly robust, I think it can possibly be problematic in terms of what it implies for the level of completeness. So I think we need kind of at a meta level we need to resolve those issues. Ultimately, of course, the challenge is of the CRVS decade. Is we need to improve the registration and the completeness of registration for a variety of regional levels. Yes, Stefan has mentioned that there are other ways of supplementing those data, and I don't disagree with Stefan with that. But fundamentally, kind of the goal must be that everyone must be in the picture, everyone must count, everyone must be registered. And I think that here what we have